Welcome to the first module in the Clinical Faculty Pedagogical Knowledge for Undergraduate Medical Education program. This presentation will summarize the content from 3 articles in the medical education literature. The first article is a summary of what skills clinical educators must master to be effective teachers. The second article summarizes learning theories from the educational literature that are applied in medical education settings. The third article is a summary of learning theories and perspectives in medical education, including adult learning and the differences between what adult learners expect from their learning experiences. We will start with a review of a classic article written by an icon in medical education. We will explore the responsibilities and attributes of a clinical educator. Dr. David Irby is a professor emeritus of medicine in the Division of General Internal Medicine and an educational scientist in the Center for Faculty Educators at the University of California, San Francisco. He has served as Vice Dean for Education and Director of the Office of Medical Education at UCSF School of Medicine. He also was a senior scholar at the Carnegie Foundation for the Advancement of Teaching. He co-directed a national study on professional preparation of physicians that produced Cook, Irby, and O'Brien, 2010, the Carnegie Foundation for the Advancement of Teaching, Preparation for the Professions, Educating Physicians, A Call for Reform of Medical School and Residency, published in San Francisco by Josie Bass. At the time this article was published, Dr. Irby was a professor, Department of Medical Education, University of Washington School of Medicine in Seattle, Washington. When combined, these domains assist teaching faculty to engage in and provide clinical instructional reasoning while targeting their teaching to the specific needs of their learners. Irby recognizes that clinicians engage in teaching using many forms of knowledge as they listen to their clinical learners giving case presentations. This knowledge base allows clinicians to form a reasonable idea of the patient's diagnosis, assess what the learner needs to further his or her education, and how to provide the learner with the targeted instruction he or she needs. Throughout the history of the medical profession, conventional wisdom suggested that knowledge of medicine, or content expertise, was all that was needed to be an excellent clinical educator. With the growing emphasis on problem-based learning, knowledge of how learning and teaching occurs most effectively is also essential to what makes an excellent clinical educator. When combined, these domains assist teaching faculty to engage in and provide clinical instructional reasoning while targeting their teaching to the specific needs of their learners. Irby recognizes that clinicians engaged in teaching use many forms of knowledge as they listen to their clinical learners giving case presentations. This knowledge base allows clinicians to form a reasonable idea of the patient's diagnosis, assess what the learner needs to further his or her education, and how to provide the learner with the targeted instruction he or she needs. Throughout the history of the medical profession, conventional wisdom suggested that knowledge of medicine, or content expertise, was all that was needed to be an excellent clinical educator. With the growing emphasis on problem-based learning, knowledge of how learning and teaching occurs most effectively is also essential to what makes an excellent clinical educator. Statements such as, quote, "If you understand your discipline, then you should be able to teach it," unquote, provides the basis for the traditional medical education maxim, quote, "See one, do one, teach one," close quote. This is an experiential model for professional education and training that builds on the close relationship between learning, performing, and teaching. A clinician's medical knowledge base is composed of what he or she has read and studied, shaped by clinical experience. An expert clinician emerges from an extensive knowledge base reinforced by a broad experience engaging with many patients over time. Clinical knowledge is organized in memory in the form of illness scripts, where clinically relevant information on the conditions, causes, and consequences of an illness are set up and edited over time as experience builds. Instance scripts are the recollections of specific patients who had been diagnosed and treated for a disease. An expert clinician is one that has developed adequate depth and breadth forming illness and instance scripts. The expert clinician distinguishes between relevant and irrelevant information when encountering a new problem accurately and efficiently. Clinical educators combine medical knowledge with knowledge of the patients on their clinical services. When clinical educators know the patients the learners will be seeing, the educator can compare what the learner has found to what the clinical educator knows from his or her own evaluation of the same patient. Combining medical knowledge with familiarity with patients gives a clinical educator opportunities to confirm patients' clinical diagnoses, monitor learning progress, stimulate practical approaches to teaching, and to motivate learning. The net result is quality patient care and quality instruction. When a clinical educator can meaningfully connect general medical knowledge with specific information regarding each patient, the clinical educator is able to establish credibility as the leader of the clinical care team. The credibility of the clinical educator ensures the learners on the team will be accepting of the educator's teaching. Clinical educators value a deep understanding of the context in which clinical practice and education takes place. Clinical educators understand clinical practice context to include familiarity with the patient population served, the social context of the patients, and the history of how clinical care has been experienced by patients. The context also includes consideration for how clinical educators and learners encounter a patient as either a case presentation or in a patient care visit. Clinical educators are experienced and recognize what conditions are most likely given the characteristics of the population the clinical care facility serves. Most learners can grasp the significance of how a patient experiences an acute illness, but need the guidance of a clinical educator to appreciate the factors that precede and precipitate an acute illness and what happens after an illness. For a clinical educator, knowledge of learners includes familiarity with individual learners, the patient care team as a group, and what is understood about the learners at a specific level of knowledge and training. The clinical educator engages learners by connecting learners with the relevant subject matter. Clinical educators need to develop strategies to understand what knowledge learners already have and what are their preconceptions and misconceptions regarding the subject matter. Understanding what are the common errors learners make is important. An example of a common error might be to see a patient with tachycardia and assume dehydration when the patient is in hypervolemic congestive heart failure. The normal development path for content understanding guides a clinical educator in recognizing the difference in what he or she should expect from a third year medical student versus a resident physician. A clinical educator strives to provide educational experiences that fit the needs of the individual learners and the group, recognizes individual learner and group motivations for learning, and provides encouragement to learn. The educational needs of the learner and the group can be found in understanding the level of prior knowledge and the degree of clinical experience. Clinical educators combine general content knowledge with general teaching methods and transform them into content and content specific instruction in clinical teaching settings. This is the process that facilitates a clinical educator teaching in a neurosurgical critical care unit while a colleague is teaching in an outpatient family practice facility. This skill set is referred to as pedagogical content knowledge, where clinical educators gain experience in understanding teaching specific content to specific learners in specific practice settings. Pedagogical content knowledge is a combination of a focused body of medical knowledge with a set of specific teaching or pedagogical approaches for teaching. When a clinical educator develops a specific strategy for conveying a focused body of knowledge to a group of learners in a specific context, the resulting strategy defines a teaching script. The teaching script, like the script of a play, dictates the order and action that takes place. Teaching scripts contain the general goals of the instruction to be given, the key teaching points of the exercise, and specific representations of the information to be given. These representations can be didactic materials, explanations, case studies, or specific learning tasks. Clinical educators are prepared to identify any misconceptions and to assist learners that are encountering difficulty. The intention of content and context specific instruction is to present content in a way understandable by a specific group of learners. This separates clinical educators from content experts who are not necessarily effective clinical educators. In addition to medical knowledge expertise and understanding of their learners, clinical educators should develop and employ a knowledge of general principles of learning and teaching. Knowledge regarding medicine is a form of content knowledge, while knowledge of principles of learning and teaching is referred to as pedagogical knowledge. Clinical educators understand how their learners learn and how that learning is enhanced by instruction. Most clinical educators have learned to teach through an apprenticeship model. Novice educators learn to teach by observing both positive and negative examples of clinical teaching throughout the course of their own educational experience. Important to the process of developing as a clinical educator is to engage in reflection by taking opportunities to review and analyze feedback from mentors, colleagues, and learners with the intention of improving and expanding one's teaching practice. Experienced clinical teachers have a repertoire of teaching strategies, including didactic lecturing, fostering group discussions, and engaging in question and answer sessions. These principles are general in nature in that they are not limited to presenting specific content for specific learners. These principles apply in many teaching and learning situations. The next article we will review in this presentation will explore learning theories and how they can be applied in clinical learning and teaching situations. Now we will discuss learning theories in general and how they can be applied in medical education. Kay and Kibble in 2016 proposed that learning theories, when understood and applied skillfully, enhance everyday teaching and scholarship. This article is focused on teaching that occurs in the basic sciences. How learning theories are described and applied in this article are a composite of faculty proposals for expanding a course in human physiology to include both didactic and laboratory learning opportunities. The combination of teaching that includes basic information and hands-on experiences in realistic situations is present here in a way that is applicable to clinical teaching. As educational research has evolved and has been applied in multiple educational settings, including clinical education, clinical educators need to understand and apply learning theories as conceptual frameworks to their teaching practices. Learning theories that describe how learning occurs with individuals include behaviorism and cognitism. Group learning is described by social cognitism and social constructivism. For each learning theory we will review, we will summarize the principles upon which the theory is based. We will define the role of the teacher in light of that theory. We will briefly explore how the theory influences how learning occurs. The first learning theory we will discuss is behaviorism. Behaviorism is rooted in late 19th and early 20th century studies that evaluated animal and human behavior, applying scientific principles in describing observed behavior. This research led to the development of psychology as a scientific discipline, when observations using animal models are applied to help understand human behavior. Behaviorism as a theory was developed from around 1900 through 1970. Major contributors to behaviorism include Edmund Thorndike, lived from 1874 to 1949, who described the principle of trial and error. Ivan Pavlov, who lived between 1849 and 1936, defined classical conditioning. Burris Frederick, or B.F. Skinner, who lived from 1904 to 1990, described operant conditioning and neo-behaviorism, while Robert Gagne lived from 1916 to 2002, defined the 9 levels of learning. These facts were taken from Bates in 2019. Learning in behaviorism is defined by observable changes, either increases, decreases, or maintenance of specified behaviors. The principles that outline behaviorism include the relationship between a stimulus and a response. Behavior can be influenced by modifying the stimulus to influence the response. Behaviorism is grounded in an empirical scientific perspective that one can only study what one can observe directly. The focus is on what behaviors can be observed in a direct relationship to a stimulus and response. Behaviorism does not explore cognitive or affective components of behavior, since these functions cannot be directly observed. Since behaviorism requires complete control of stimulus to influence response, the teacher plays an essential and active role. The teacher establishes and maintains complete control of the stimulus-response relationship within the learning environment. The teacher determines the types and schedules of exercises that reinforce desired demonstration of the targeted behaviors at specific times. Desired target behaviors can include following appropriate social rules, professional behavior, or to achieve a passing score on a test of well-defined information. In behaviorism, the role of the learner is described as a tabula rasa, or blank slate. The learner responds to the stimuli introduced into the learning environment by the teacher. In this approach, the learner is passive while the teacher acts as the source of all knowledge and skill. Learning applications for behaviorism as applied in learning environments is a balance between positive and negative reinforcements. High order performance of target behaviors can elicit positive reinforcement, such as extra attention from teachers, praise, good grades, recognition, achievement awards, and access to additional or future learning opportunities. Inaccurate, incorrect, or inappropriate performance of target behaviors can lead to negative reinforcement, such as punishment. Alternative responses include continued instruction until target behaviors are mastered. The next learning theory we will explore is cognitivism. In cognitivism, learning is understood as an internal mental process that involves receiving, decoding, storing, and retrieving information. When a learner is actively searching for information from memory and from experience, modification in behavior can occur in response to new insights gained from information processing. While behaviorism focuses on observable behavior in relation to stimuli within the learning environment, cognitivism is focused not on behavioral outcomes demonstrated, but more on the mental process that lead to modifications in behavior. Cognitivism developed in parallel with behaviorism historically, with most research conducted between 1910 through 1970. Notable contributors to cognitivism include George A. Miller, who lived from 1920 to 2012, for chunking and the magic number 7, plus or minus 2, John Sweller, born in 1946, for cognitive load theory, and Leon Festinger, who lived from 1919 to 1989, for cognitive dissonance. This information came from Bates, 2019. Cognitivism describes the mind as an information processing system. The learner forms mental models or representations referred to as a schema or schematic networks. These schematic networks describe lived experience and include information, knowledge, episodes, relationships, and interactions the learner has encountered in his or her environment. An expert is an individual that has complex, highly functional schematic networks. Not all learning experiences are equal in ensuring long-term retention of information. When expanding declarative knowledge such as facts or information, repetition and rote learning can be an effective strategy for short-term memory. Deeper understanding of content and longer retention of information come from learning experiences that involve higher order thinking skills. New skills and knowledge are combined with prior skill sets and knowledge bases. This approach is called meaningful learning. Most knowledge and skills are subject to forgetting if not used with enough frequency. The teacher is highly active applying cognitivism in his or her teaching practice. New information is represented in an organized, structural manner in manageable chunks that can be understood and remembered by learners. When bringing learners along from novice to expert level, the teacher begins with basic information and skills, then progressively moves on to more complex, higher order knowledge and skill sets. Information is organized based on defining and discriminating features, with examples that support these features. Experience with application, integration, and synthesis of knowledge and skills is essential to the cognitive process. Learners are active in the learning process as they must pay attention, retain, and reproduce the knowledge and skill sets presented. Cognitivism is useful for learning experiences that require attention to organized constructs and principles. New knowledge should be presented in a way that recalls and then builds on prior knowledge and skill sets. The design of instruction should move from basic information and skills to more complex over time, presented in chunks that are manageable. Content is presented in ways that employs multiple senses and employs many strategies to enhance long-term retention and recall. Connections between prior knowledge and new information are reinforced with examples and experiences that emphasize the value of the new information. The next theory we will discuss is social cognitivism. In social cognitivism, learning occurs when observable increases, decreases, or maintenance of target behaviors are noted. Albert Bandura, born in 1925, through his theoretical insights into role modeling, self-efficacy, and triadic reciprocal causation, provides the foundation for social cognitivism. Triadic reciprocal causation describes the interplay between an individual's personal situation, environmental factors, and how they all influence the individual's behavior. In social cognitivism, some aspects of behaviorism apply, but are expanded to include how observational and vicarious experience contributes to learning. Learning does not have to be explicitly reinforced for a behavior to be internalized and then demonstrated. A learner will or will not imitate a behavior depending on the learner's experience observing others demonstrating the behavior. Other elements of cognitivism include included in social cognitivism are listed above. The teacher continues in an active role with the extensive focus on the learning environment. The teacher ensures that the appropriate role models are present to the learners and that the target or desired behaviors are reinforced through effective stimulus response mechanisms. The teacher optimizes observational and vicarious learning opportunities within the learning environment. Behaviors that learners can successfully imitate and perform are emphasized. Learners are actively encouraged to pay attention to behaviors that are desirable and not desirable. The teachers ensure the learners are motivated to reflect desired behaviors and avoid undesired ones. Similar to behaviorism, the learner is still responding to stimuli in the learning environment, but becomes more active in the overall learning process. The learner is encouraged to pay attention to demonstrated behaviors, remember those behaviors and the responses observed, and then decide which of the behaviors are appropriate to reproduce or not within the learning environment. Social cognitivism provides a frame for understanding the interaction between groups of learners within a learning environment. Management of the learning environment, socialization, and the strategic use of interactions with learners can influence the behavior of all learners. Social cognitivism is useful in applying attention, retention, motivation, and reproduction in skill instruction. Learners' thought processes are considered when explaining learner behaviors. Constructs that come from social cognitivism include self-efficacy and self-regulation, emphasize learner contribution to successfully completing a learning task. A list of applications are included on the slide here. In medical education settings, the role of the clinical educator as a role model and how learners perceive and express desired and undesired behaviors. The clinical educator is teaching even when he or she is not aware they are teaching. The last theory we will discuss is social constructivism. In social constructivism, learning occurs when learners internalize and adopt experiences from their learning environment. Knowledge and thought are constructed through social interaction with family, friends, teachers, and peers. Social constructivism places a great deal of importance on the roles of community and culture in the learning process. This approach to learning encourages learners to discover the relationship between their prior knowledge and new bits of information presented in the learning environment. Like constructivism, social constructivism developed along with cognitivism from around 1930 through 1970. Important contributors include Lev Vygotsky, who lived from 1896 to 1934, who developed the zone of proximal development, and Jerome Brunner, who lived from 1915 to 2016, who developed scaffolding and discovery learning. Again, this information comes from Bates 2019. An essential component of social constructivism is that all learning is social. Learners develop knowledge and skills by employing the tools provided by culture, such as signs, symbols, and language, interacting within the learning environment. The zone of proximal development was described by Vygotsky. Each learner has a baseline of knowledge, skill, and development that defines what the learner can do within the environment independently without assistance or guidance. Beyond that baseline lies a zone where the learner could not function even with assistance or guidance. The zone where the learner cannot function defines goals for future acquisition of knowledge, skill, and development. Between these two areas is the zone of proximal development, or the ZPD. The ZPD is the interface between the learner's comfort zone and the zone the learner aspires to reach. In the ZPD, the learner interacts within the learning environment using the resources available, particularly those individuals within the environment that have some or all of the knowledge, skills, and developmental level the learner aspires to reach. These individuals are known as more knowledgeable others and act as guides and teachers for the learner within his or her ZPD. These individuals build on the baseline the learner has in a process called scaffolding, as described by Brunner, to gain increased knowledge, skill, and development. The teacher is one of many more knowledgeable others that facilitates learners as they move through their own ZPD to a higher level of knowledge and development. The learner uses the tools provided by culture and engages with more knowledgeable others to master a higher level of understanding, knowledge, and skill. Learners interact and support each other in the social constructivism learning process and may act as more knowledgeable others for their peers. The impact of social constructivism in medical education is considerable. One could easily imagine an outpatient facility or an inpatient ward service in terms consistent with social constructivism. There is a defined learning environment with the universally recognized purpose of providing care to patients. There is a unifying culture of medical professional practice that defines expectations for knowledge, skill, experience, and behavior. Individuals within the learning environment include patients, support staff, nurses, advanced practice specialists, medical students, residents, fellows, and attending physicians. These There are learners of various knowledge, skill, and developmental stages working and learning together, each with his or her own ZPD. Each learner is attended to by the group, acting as learner and more knowledgeable other depending on the situation and their own needs and capabilities. We will now discuss adult learning as a perspective for understanding and using the four previous learning theories for adult learners. Adult learning points out the differences in how adults learn, making a distinction between how children are taught versus how adults learn. Dr. Philip Ozua published this summary on learning theories for physician education in 2005. This article provides a useful summary for all of the learning theories with emphasis on adult learning. Adult learning does not provide a theory for learning, but does provide insight into how the learning theories we have reviewed come together to meet the needs of adult learners we encounter in our medical education settings. Adult learning was defined by Malcolm Knowles, who lived from 1913 to 1997, who argued adult learners, unlike children, wish to be in control of their own learning. Extensive research in adult learning occurred from 1950 through 1998 and defined what assumptions could describe adults as learners. Adult learners need to appreciate and understand the value and the utility of what they are expected to spend time learning. The benefits and consequences of embarking on a course of learning needs to be clearly understood before moving forward. Adult learners are generally self-directed and autonomous in their learning. Adult learners have a need to be seen and treated by others as capable. Adults include their experience as an asset and expect that experience will be both respected and applicable in new learning situations. Because adults have extensive experience, future learning should employ educational strategies that build on prior experience with new experience. Once adult learners are convinced that new learning will have value, they they tend to be motivated and engaged in new learning. Learning for adults does not tend to be subject focused, but rather problem centered, task centered, or life centered. Adults generally want to learn to perform tasks or solve problems faced in real life rather than simply increase content knowledge. Adults are motivated to learn to some extent by extrinsic factors, but are most often driven by their own interest, desire for self esteem, or goal attainment. Adults are motivated to continue to learn, grow, and develop throughout their lives. Adult learning is not a freestanding learning theory. Adult learning employs any and all of these learning theories reviewed in this presentation as applicable to the adult learner and the learning situation. Behaviorism may be most useful for adult learners that are learning new and unfamiliar information or skills that are not informed by the learner's experience. Cognitivism is applicable in situations where new information becomes knowledge that facilitates the adult learner to solve new problems or problems the adult learner was not able to solve previously. Constructivism facilitates the adult learner's ability to incorporate new information or skills with prior knowledge and skill sets to advance learning and developmental levels. Since adult learning provides new knowledge, skill sets, and developmental advancement in social situations, social cognitivism and constructivism are important to round out the theoretical underpinnings of adult learning. Adult learning understands that as a person increases knowledge, skill, or developmental level, that individual's self concept moves from dependency early in the process as a novice to self directed and autonomous as he or she progresses toward expert status. Prior to an educational process, adult learners have a reserve of experience that informs and expands over the course of the educational process. Experience provides a rich source for current and future learning as the learner becomes more independent. With progress, the adult learner moves from anticipated application of knowledge to immediate application of knowledge. Learning shifts from subject oriented to problem centered. The adult learner is motivated through his or her learning to assume new roles within the learner's social setting. This is clearly demonstrated in medical education setting where a medical student moves from subject-oriented, dependent learner who, by the time he or she graduates residency or fellowship, evolves into a problem-oriented, self-directed, and independent practicing physician. Irby in 1994 discusses what clinical educators need to know to be effective. Six distinguished clinical educators provided insight that differentiates clinical educators from content experts. Both clinical educators and content experts have extensive knowledge of the medical subject material. Moving beyond content expertise, clinical educators have a knowledge regarding the needs and capabilities of learners. Clinical educators have a deep understanding of what is going on with the patients on the clinical service. Clinical educators understand how to teach, including teaching strategies that are grounded in educational principles and learning theories. Content experts are unlikely to engage actively with learners, the patients on the clinical service, or have a background in education or learning theories. Content expertise alone is not sufficient for clinical teaching. Kay and Kibble, 2016, provide an introduction to a few of the most important and commonly applied learning theories that guide teaching for individual learners and learners in groups or teams. Ozua in 2005 provides an introduction to adult learning, where commonly applied learning theories are combined and applied for adult learners in medical education settings. These articles can help provide a guide for you to understand, define, and describe your role as a clinical educator.